actually in parenting and interventions related to parenting and child growth intervention. I actually came as a parent myself when my child was 2 years old, and she had this very loud, boisterous type of way in screaming and notifying me, "Mommy, yes, I'm excited. Oh, mommy, I'm sad." It was just really hard to interpret her emotions sometimes. And so I actually started with parent-child interaction therapy and learned filial therapy and how to better understand how to integrate child development through the eyes of the child. And so that has since has exploded in my world, and over the past 20 years has translated the way in which I view and I do treat with individuals, clinicians, as well as providers and parents themselves. So uniquely, when I started working in this field, I started just seeing things just slightly a little different, because clinically, depending on which area or which field you're in, right, whether it's in medicine or whether it's in psychology, we are adapted to different disciplines, correct? And so to see and to view it from different angles and perspectives requires effort sometimes. And additional education. So to be able to do that, I had to take both my personal experience and advancing education and knowledge and just learning through life, as we all do. And so I thank you for having this parenting conference, because very rarely do I get to experience and see these opportunities with having these very different dyadic experiences. They're very rare. So thank you guys for having this. I think it's beautiful and wonderful for advancing the field, both in childhood development and in parenting. So today we'll be talking about a case, and we'll discuss a little bit of a theoretical framework that my colleagues and I have put together, statistics based on early childhood and infant mental health, which is a new topic that's emerging in the Pakistan area, which is where I was participating in originally with the Baby Matters conference. And we'll talk about the methods and procedure we utilize for this illustrative case, treatment results, and then final tips and takeaways. If I do speak rather quickly, it's because I'm Latina in nature, Puerto Rican. So the Latina sometimes comes out, and I can, kind of rattle off. So please remind me to slow down if I need to, Andrew. And if I need to repeat something, I'm happy to do that. So when we started working into the field of infant mental health, this is how my colleagues and I, both in the American Psychiatric Nurses Association, I serve as a assistant chair for the Organization for Child and Adolescents. And the field of infancy was not very well known in that at the time. If I want to say it was about 8 or 10 years ago. And so I essentially was the person bringing it to the forefront. When you have a history and a background in pediatrics, you have a different viewpoint in child development. And so it was a really great collaborative effort to be able to do that. And so we put together a theoretical framework to better understand what the biopsychosocial framework is for better understanding through a different lens, both the biological perspective of the infant and the child, and also for the families and the dyadics and the environments they're being exposed to. So the biopsychosocial model is not new to many of you likely, but we had to reframe it so we could better understand it when the infant and the child within the center. So we had to learn what their stress reactivity or attachment was with their parent. And attachment is sometimes confused as the parent attaching to the child, but it's actually the child attaching to the parent. But we switch it in nursing, and we call that bonding. When the parent is bonding, it has a reciprocity with the child. We want to know about their cognitive functioning. Are they born prematurely? Are there any delays in that area that might be affecting their biological stress? Andrew did let you know that I did a dissertation on salivary oxytocin with mothers with premature infants, which is where my nursing experience started, with having the separation between mother and baby in a very stressful environment. And the only way we could reunite the mother with the child and to reduce their stress to lung responses is through skin-to-skin contact and touching and holding and breastfeeding and latching. And so that study showed that as mothers held their babies in skin-to-skin contact, their oxytocin levels would increase and the cortisol levels would decrease over time. So it took some time for me to understand what those biological measures were, to be able to help understand the interventions that are utilized to be able to reduce those stress reactivities and responses. Also, the psychological aspect of it is the knowing emotion regulation, and through child development, understanding that children don't know self-emotion regulation, that they require the help of the parent and the caregiver to be able to help with emotional regulation, which usually does happen with attachment as well. Parent-child behaviors as well, in terms of how that dyadic relationship works, what their temperament is naturally. You can actually have a parent who is very calm and less stressed, go with the flow, but then have a child who is very hyper intensive in nature and not being able to mesh the two together. So the more that you can understand the temperament of the family and the environment, the better it is to be able to psychologically understand what's happening in the framework of the dyadic relationship. The mental health of the parent as well. If there's a history of, let's say, anxiety or depressive mood, or even a bipolar diagnosis, then that can actually affect emotion regulation in between the relationship between the parent and the child. And lastly is the social environment, which many of us already know that any experiences of stressors like adverse childhood experiences, what the family structure looks like. We commonly no longer have, you know, two-parent households. We have many children in the US that are being reared by their grandparents, or they have one parent, and then it just takes a village. And so we want to really get a better understanding of what the underpinnings are with the child in the center. And you'll see there's a lot of crossover. There's learning what their child's IQ is, what if there's any histories of parent substance abuse, what's the parent's IQ level, is there any history of trauma, or what their education levels are. So a lot of those factors are already taken into play, and that's kind of, we just want to conceptualize that in the psychosocial theoretical framework. Statistically, when you're trying to understand what, let's say, what infant early child mental health disorders appear like, it's very challenging to find really accurate data because there's lack of awareness and difficulty in assessing and diagnosing young children. So what looks like a child who might be in distress could be a tantrum, but not really fully understanding and diagnosing as a child who's having separation anxiety. So there's completely two different things that we're trying to look at without knowing the context and without knowing the framework. So what we do understand is that in vulnerable populations, the youth exposed to adverse childhood experiences, trauma, poverty, parent substance use disorder, or maltreatment or abuse are more likely to have more marked symptomatology of mental health disorders. A meta-analysis recently identified that the rate of mental health disorders in the ages from 0 to 7 actually is approximately 20%. And during a Google Scholar search during the following prevalence, we found in certain infant early childhood mental health disorders. So I preface this by saying the diagnostic tool for the DSM is standard for the use of children ages 6 and older, and that the diagnostic, let's say, diagnostic criteria we're utilizing and looking at are from the actual DC 0 to 5, from 0 to 3. So in separation anxiety, the most common anxiety disorder in children under the age of 12, it affects about 6% of children. Reactive attachment disorder, it is more commonly seen in children who have been in severe deprivation or in institutions, foster care. But this is also seen with children who have extreme distress in their life, have had multiple hospitalizations, severe traumas related to being separated from a parent. These are minor, but they can be seen between 1% to 2% of children. Autism spectrum disorder, which has evolved over the past millennia, I want to say. It's about 1 in 36 children are identified with autism spectrum disorder, and this statistic is starting to shift a little bit. We almost said there was like 1 in 6 that are now changing in the US, which is really a marked difference from the past 5-10 years. Distributed social engagement disorder is nearly a quarter of children in high-risk environments, such as foster care, institutional care, and others suggest that it may be even closer to 8%. So that is a significant one related to parent-child relationships, and the way in which the child reacts to the parent. Selective mutism is a prevalent in the rates of 1.9%, let's just say. Oppositional defiant disorder varies greatly, but an estimated range of 2% to 11%. And ODD is sometimes a precursor for conduct disorder. I don't ever shift to that. That's not my first thing that I go to. I always try to understand child development before I go to the severity of conduct disorder, but that's something that clinicians are mindful of. Failure to thrive in the United States is seen in about 5% of children in primary care settings. Most cases of failure to thrive involve inadequate caloric intake caused by behavioral and psychosocial issues. So when I present this issue as failure to thrive, most of my pediatric clinicians are like, well, they're dropping. It must be, a physiological thing. That's the first thing we're going to try to find. Is it an organic reason, right? Is it a malabsorption? Is it something related to what they're eating? What's causing the failure to thrive? But over time, if that continues to drop and the reactivity and the relationship between the mother and the child is not attached, and sometimes the cues are not well read, then sometimes that's just a drop in caloric intake that can be addressed in as simple as education or just some parent-child interactive therapy to help with the increasing attachment. Unaddressed failure to thrive in patients younger than 2 years of age can lead to significant long-term neurodevelopmental complications. And children under 2, when the brain is rapidly growing and developing, like most of you guys understand, within the first 5 years, is when the brain is fully developing at this age range, and without having the proper nutrients, then that can be markedly affected. That can include reducing IQ, increasing neurological cognitive behavioral challenges, and maybe long-term in the end have symptoms of ADHD, learning disabilities, and impaired communication skills. And postpartum depression, which the prevalence is around 14% of postpartum mothers now, which has also been something that's been more widely recognized. I think many of us knew that there were the baby blues, but weren't understanding that there could be a significant relationship between that and depression. So we'll get to that in the case a little bit. And I always like to put a global flash here because AI is running the world now. So I like to put it here so you can see where some of this data comes from and to know what the resources are. So the BMC Public Health, National Institute of Health are resources that were being drawn for the AI scope of what the postpartum depression looks like now. That prevalence level globally is 17.7. So with a 95% confidence interval, that's a pretty significant increase from what I just presented. And factors that are related to this are, as we just talked about, can actually lead to maternal mortality, infant mortality, and if they're not being properly addressed. So that was something new that I was kind of looking at, that it's when you think about relationships, you're not necessarily thinking about mortality, but that those are things that we have to start looking at, that could be a possibility when we're looking at detachments or relationships related to the young child and the mother who might be suffering and dealing with stressors beyond what she can do on her own. So kind of to address these gaps in the presentation is going to further describe, the care of a dyad utilizing an illustrative case. This is the manuscript that you can reference if you'd like to read a little bit more information about how methodology came about. But our design basically was to utilize a scenario that includes the early detection of infant mental health secondary to failure to thrive. The setting was a pediatric primary care clinic with a referral to a psychiatric mental health advanced provider. And the aim was just to highlight how integrative care can promote optimal early childhood growth and development and prevent long-term mental health problems. So this is kind of trying to bridge that gap between the different sides of the biobehavioral and the psychologic and the psychosocial. So this is like the action of the biopsychosocial framework in itself by working collaboratively with other disciplines. So the sample was a 6-month-old male with his 20-year-old single mother at a primary care clinic. At birth, the baby weighed 3.5 kilograms. So at that time, the baby was 50th percentile for age and gender and born term. The mother didn't wean off breastfeeding, so she was formula feeding only at the time. When the child came for 2-month-old, the weight was 4.8. So you could see that there was an increase in weight, but that the percentile wasn't appropriate for the baby's growth and the age of the child. And the mother notably was concerned about the baby spitting up. It caused her a lot of stress that the baby kept spitting. So the pediatrician then recommended a formula change to see if that would increase more starch. So that way it would treat for the regurgitation after feeding. At the 4-month follow-up, the baby's weight within was 5.4 kilograms. Okay, another increase, but a gradual, slow increase, not sufficient enough to meet the demands of the infant, and was then now at the 5th percentile. So then the infant was started on twice daily ranitidine for reflux, trying to appease, or let's say understand the mother's concern about the continuous vomiting. That was the biggest concern. Now at 6 months, the presentation was at 5.9 kilograms, and then that's when the primary care provider was like, okay, we talked about providing the proper caloric intake. We've been treating the reflux, but let's see what else might be going on because the child is still not growing adequately. And there were no other symptomatology related to any other organic, let's say, symptoms for the reason why the child would not be gaining appropriately. So when the provider then asked if she had help at home with baby, because this was a single mother, first child, the mother reported that she was a single parent, had difficulty with relationships, and experiencing periods of depression and irritability. The mother completed the Edinburgh Postnatal Depression Scale with a score of 17, indicating a risk of postpartum depression. So from that, the provider then understood that this could be something more psychological that needed to be addressed and needed further evaluation. So then at that point, diagnosed non-organic failure to thrive and made a referral to a psychiatric assessment, or let's say practitioner, to do a comprehensive psychiatric assessment. I don't know why my screen is not shifting. Okay. Okay. So the diagnosis etiology for postpartum depression, as we mentioned previously, that it's not uncommon for mothers to feel a little overwhelmed, anxious, have mood swings, crying spells, irritability, and difficulty sleeping. And this time is notably known as the baby blues, or like transient depression, typically resolves within the first 2 weeks as the progesterone and estrogen levels start to adjust. If depressive symptoms continue beyond 2 weeks and they're having difficulty taking care of themselves, taking care of the newborn, or thoughts of harming themselves or the newborn, should probably seek medical help or additional support. For failure to thrive, pediatric non-organic failure to thrive means a child is typically under 2 years old, has stunted growth, and no known medical reason. After ruling out a medical possibility, whether it's GI, endocrine, cardiac, the cause may be discovered to be an economic, psychological, or social problem within the household. So a further evaluation, depending on social services requiring meeting those economic needs or with a psychological evaluation, is usually kind of preferable. So for screening and evaluation for the child, we want the provider, so we have 2 different providers working together collaboratively, was routinely to document the child weight and height and identify how the growth chart looks, because usually providers use the World Health Organization growth chart depending on their age and weight to see how the trajectory looks. So it should look like a nice curve based on the child's growth as they're aging, but a lot of times failure to thrive, you'll start to see a drastic dip, and it'll kind of just be a marked drop sometimes if that happens. So usually identify that as 2 percentile drops. Additional symptoms are related to delays in the development. So they might have avoiding eye contact, not making sounds at the appropriate age, delayed age appropriate social skills, not smiling or laughing, interacting with the parent, delayed motor development. So not rolling over at 4 or 5 months, or delayed more at like 8 months, sitting appropriately, standing, walking, or they're sleeping too much. On the other side, when I feed to child who are for failure to thrive, because their stress responses are adapting and they're not crying for hunger cues, then that doesn't respond to a parent as a child being stressed or being hungry, but that the vomiting is a problem and that I need to stop the vomiting. So the choice that's being made is to do what's best interest of the child based on that parent's perception. So sometimes it's just a matter of education and providing them the resources and support to be able to better understand what the feeding cues look like.
Couple more minutes, Jessica. Couple more
sorry?
minutes. Couple more
Okay,
minutes.
thank you. Couple more minutes. Okay. So for postpartum depression, it's recommended to screen with the Edinburgh postnatal depression scale. The American Pediatrician recommends to screen at 1, 2, 4, and 6 months, and that the postpartum blues can tend to develop between 10 to 14 days after delivery, but that should be monitored. For treatment, you want to continue current treatment, daily feeding, diary, monitor caloric intake for symptoms for 2 weeks, add in parent symptoms during the feedings to see if it's the parent reactivity and response of the feedings and what that feels like. Does it make your stomach hurt? Are you feeling worried? Like, is it more of a parental response that we need to address to? Refer to a GI or nutrition if it's necessary. For the parent, individual psychotherapy and counseling could be the initial start of just modeling to the parent how to be more sensitive and attuned to our infant's feeding cues. And over 6 months, a month, over 6 months, and sometimes refer to home health or actually nursing programs that help in the home to be able to identify these feeding cues better. Additional recommendations were for ongoing maternal follow-up with psychopharmacology if necessary. So if the depressive symptoms continued and not being able to be responsive and react to the child, then sometimes SSRIs might be initiated, refer for additional treatment like psychoeducation, home health interventions, outpatient parenting interventions, or parent-child psychotherapy, especially in cases of trauma. So 6 months later, as a result from working together and collaboratively between the primary caregiver and the mental health provider, the child's upward weight count to the 20-50% was where the baby actually started at initially. Mother was more responsive. Her Edinburgh postpartum scale decreased and her PHQ-9 actually decreased too. So she didn't require SSRIs at the point. She just needed some education and learning as a first-time parent. Presented with so the results is that treatment of the diet resulted in early infant parent intervention that reduced maternal depression and normalized infant growth. The tips and takeaways are early screening infant early childhood mental health among families with children ages of 5 is very important. As soon as 2 weeks of age is something that I can actually notice and detect where the parent is not able to understand feeding cues of the child. Sometimes it's overfeeding actually, which then leads to vomiting. So it's kind of similar in terms of being able to respond to the baby's cues. And as the child grows and develops, not understanding that the child just wants to be held or, being helped with their motor function and development, that it's not necessary to soothe them with feeding. Especially mostly in the comprehensive assessment of infant or child mental health problems, it could be not detected with one interaction, but you might need to have multiple interactions to be able to see what the cues are and what's happening. You may have to identify appropriate treatment to promote optimal growth and development over time by monitoring both the relationship and the growth and development of the child and how the parent is responding with the interactions with the relationship after birth. Thank you. Did I make the time, Andrew?
It's we thank you very much. Appreciate it, Jessica. It's that's very helpful and insightful. You've done a lot of great work and it's inspiring. And so thank you very much. Nasim will introduce the next speaker.
Yes, I'm unmuted. So I'm delighted to invite our next speaker, Dr. Saidur Mashriqi. He's an associate professor of public health at North South University, Dhaka, Bangladesh. He's an honorary professor of Bangladesh University of Health Sciences, and he serves as the treasurer of the Bangladesh Early Child Development Center. He has led NIHR and MRC-funded research, including the groundbreaking work Prevention of Child Injuries through Social Intervention and Education, and a childhood burn prevention program in rural Bangladesh. Dr. Mashriqi has published over 118 peer-reviewed articles. He served as a reviewer. He has been an assistant professor at the Center for Medical Education in Bangladesh, and he currently serves there as the focal point for quality assurance and medical education. Welcome, Dr. Mashriqi.
Thank you, Nasim. Okay. Hopefully my screen is visual to everybody. So this is not a very good research. Just I'll share my around 20 years experience how a research in a service delivery in country mainstream. And this is now scaled as a child development parenting program in Mother and Child Affairs Ministry, but it was initiated as a child injury prevention program when we started as a research for child injury prevention in Bangladesh. So it started in 2004 2005, when actually we conducted Bangladesh Health and Injury Survey in Bangladesh, and we found the child injury is the leading cause of death in Bangladesh. In 1 year to 18 years, whole range, the number one cause of mortality was injury. And to address this issue, and estimated on that time around 30,000 children die every year. So one of the component was the supervision, can and address the injury prevention, and considering that supervision, we prepare a daycare, community-based daycare model, and actually I'm going to present that. And we consider the safety, nutrition, early childhood development, stimulation, school readiness, all of the thing. Although that time primary focus was reducing the injury death. So it was a community-based daycare center. We found that actually during breakfast to lunchtime, more than 50% injury, death, and illness occur. And a qualitative study showed that actually during that time, father go out after his breakfast, elder brother and children go to school, mother become busy with their cooking and household chore, and that time toddler become vulnerable to different kind of injuries. So considering that scenario, we identified an intervention that if anyone in the community can give a space and willing to supervise the children, we can save these children. And that was the concept. So in a community around 100 household, a community member actually provided a room, and someone in that household willing to serve as a caregiver. And condition was that safe environment for the children, prevent the injury, and we provided early childhood development activities in that center. So our caregiver normally married, because we didn't want to migrate. So we trained them in the community and they stay there. And we provided those women a week-long training on early childhood development, parenting, caregiving, and injury prevention, safety promotion, on these things. So it is completely community initiated. This figure is called Village Injury Prevention Committee. They actually decide and provided a space where actually we started our program. So this activity not only provided the safety and care of the children, it also provided the empowerment, because we provided 2,000 taka. It is $20, less than $18 a month as a volunteer for his volunteer remuneration, and it makes those women an identity as a teacher, and they become empowered and honored in the community. And these women's receive training not only child development, safety, the parenting training. Actually, they train the parents on training parenting. So they become not only the teacher of the children, they become the teacher of the mothers as well in the community. So in this activity, child safety was ensured, and along with the child development was ensured. But in our program, we didn't structurally evaluate the child development issue, because the activity we did, it is already proven in many other studies. But we formally evaluated the safety issue, and we published that actually how it is effective in injury prevention, as well as it was cost effective. We published it in American Journal of Pediatrics. So major achievement of this program in Bangladesh, I mentioned it. We started in 2005, and it scaled up, taken up by the government of Bangladesh, Minister of Women and Child Affairs. We promoted to incorporate in the health ministry, but actually it is more accommodated in the Women and Child Affairs Ministry, and they adopted and incorporated in the ministry as an integrated community-based center for child care, protection, and swim safe facilities. They also, we had another program, swim safe program, for teaching swimming learning to protect from drowning, because drowning is among the injury. Drowning actually itself, drowning is the leading cause of children 1 to 18 in Bangladesh. So they also took both of them. So this mother actually taken the responsibility, this center taken the responsibility of the supervision, and they also ensure swimming training by another swimming instructor in that village. So it has been in the first phase in 2022. It has been started in the government sector in 16 districts and initiated with 8,000 center, and each center 25 children 2 to 5 years. And now it is ongoing, and hopefully next year actually it will be maybe 100,000 like this, because this time actually they are thinking big project for all over the country. So my presentation is very short. So this program actually together provided us a safety and development together, a unique model, both survival of the children and the development of the children. This kind of program actually helping to empower the women, and it is also proven at an injury prevention program, and it is scalable program. Already government scaled it up. So I have already mentioned that we formally evaluated the effect of injury prevention, and it's very effective in drowning prevention, other injury prevention. It is 82% protective. We found it is also found the cost-effective program. So I'm completing my presentation with a video. One center actually I tried to show you. Thank you very much. This is all about my activity.
Dr. Mashgiri, this is such inspirational work. What a powerful reminder for us that if you want to make something sustainable, it has to start locally. And I've heard your earlier presentations on the amazing work that you've done on burn prevention in homes in Bangladesh for young children. So we've got a couple of minutes. We don't have anything as yet on the chat, but we have time for any comments, or if people want to ask anything. So we're open for a few minutes. We do have time. So anyone from the participants, any comments?
I don't know how to raise the hand, but can I ask a question?
Yes, yeah.
Yes. This impressive 200,000 children and getting into the main, by the government. How were you able to do that? We hear so many wonderful interventions, but that level of scale up is difficult to find.
Thank you, Nusrat. Actually, this is the main information here. We started with 5 initially, then actually 300, then 3,000 center with different donor. And if donor mainly, we convinced the Bloomberg Foundation, who that actually who are really have the capacity to push government. So we work with Bloomberg Foundation around 7-8 years, and during the last 3-4 years, actually, we together they appoint another organization called Synergos. So CIPRB Synergos actually make a advocacy body, and by that time I'm in the Bangladesh ECD network as a treasurer. So ECD network is a network for 167 organizations who are working the early childhood development. So this network actually can create a force which actually can convince Ministry of Child and Women Affairs, because when actually started CIPB, they thought it is a health ministry program. So they tried, but they failed. But during this initiative, actually, we find out and we convinced the minister, and minister actually decided, and they feel it is really a important thing. And that's why actually this way it becomes scaled up.
Well done. Thank you.
We'll very quickly there's a hand up. So one last question, and then people can put in comments. I'm not sure how to pronounce this. This is Sibagwa. There's a hand, or Robin. And you're mute. Can somebody?
Are you hearing me?
Yes, we can. Yes.
Yeah. Thank you very much. I'm thanking all the presenters there, though I missed the first one, but I've liked and enjoyed the second presenter. Now, my question is, how do they come to have the caregivers, the ability of handling these children? How do they select those caregivers? How do they get them?
Okay.
Secondly, the ratio of the children, because we would think 25 per 1. How do you handle that? Because I don't know, there seem to be many.
Thank
Am
you.
I clear?
If I understood your question properly, so you see every village we prepare a injury prevention committee. They took the responsibility to safety and development of the children. So we propose them. They find out a home and a caregiver who is willing to provide the support. So these willing people, and around it is at least 10 years education or above. This is the minimum qualification, 18 to 35. This is the age range population. And we train them by a very qualified trainer. It's week-long training where actually early childhood development, parenting, and the safety. So this training, actually, we started this training with this induction training. We started the program, and we have a 10 100 daycare center, one trainer and monitoring officer, we call them. She actually always monitoring the over the month and identified the issues, and again they called cluster meeting, and they come together and discuss the training issues. So in this way, gradually we make those trainer become capable and efficient. As I have mentioned that married women we decided. So normally those ladies never left that place, and they become gradually equipped with different kind of skill and knowledge.
Thank you, Dr. Mashkari. We need to move on. People, please. I know, Adnan, your hand is up. Just ask in the chat box any questions. Thank you once again. Thank you very much.
Thank you.
So we move on to our next presentation, and delighted to invite Professor Anila Maqsood, who's a very dear colleague. We work closely. She's a distinguished academic with over 20 years of experience in teaching and research in the field of mental health. She holds a postdoctorate in mental health from Queen Mary University of London. She's a professor of psychology at the National University of Modern Languages. She's also the director of the Research Center for Suicide Prevention, which was set up in collaboration with Pakistan Institute of Living and Learning at Fatma Jinnah Women University. Her main focus or interest is implementation science and development of therapeutic interventions aimed at enhancing mental health and human capital. Welcome, Dr. Anila.
Good evening from Pakistan. Thank you so much, Professor Naseem, and thank you, Professor Nusrat Hussain, for inviting me at this event. Perhaps I was waiting for this conference because there's an ongoing PhD level study, and I was really hoping to have suggestions from our audience. So I would like to share my screen. And I hope this is visible to everyone. So, yeah. And I hope this is visible.
Yeah, it is. Can you do the full screen? Like a full screen.
Yes,
Yeah.
exactly. I'm looking at how to do this.
It's way down, down. Come
yeah,
down.
Exactly. Can you please help me out for yeah. I need to zoom it out. Yeah. Perhaps it's not appearing. If this is visible, I can continue with this.
Okay, that's fine. We can see.
Yeah. All right. So the topic of today's talk is parenting and adolescence mental health, interlinking family dynamics, personality, and personal vulnerabilities. Before jumping to theoretical underpinning of this research work, I would like to explain that it's part of our ongoing PhD level study. And initially, we have a very specific agenda and objectives in our mind, and it was about examining socio-cultural understanding of parenting practices and its outcomes in our cultural context. With this, we are aiming to identify predictive influence of individual, family, and social environmental factors that potentially may influence adolescents' mental health. At broader level, we are trying to see how possibly we can derive a risk profile which can help us to see how to deal with clinical and at-risk population later on. And based on this study results, which is purely quantitative at this level, we are aiming to extend up to a level where we would be engaging in a qualitative aspect as well. And we are trying to co-develop content for our parental training programs. Bringing on experience in working in different clinical trials and the kind of research work we are doing as part of different universities in Pakistan. And as far as my personal observation and research evidence is concerned, we are in need of having proper training program, parental training programs. And this is what we are looking forward. Based on our results, we will propose a sort of initial parental training program for its pilot test. If I explain the background of this study, perhaps everyone is clear about that adolescents' mental health is a critical global public health concern, and it's a leading cause of illness and disability. It's such of an important issue that it not only affects adolescents, but it impacts their families and communities. And as far as broader theoretical conceptualization of this study is concerned, we are looking at WHO's journal definition of well-being that actually looks at how to promote overall well-being and helping individual to enhance their potential at the maximum level. As far as the research situation in context of Pakistan is concerned, despite of global recognition of adolescents' mental health, it remains a serious neglected area as far as policy and research in context of Pakistan is concerned. Introducing this in terms of different empirical evidences and theoretical relevance, there's a strong a theoretical justification that is available as far as literature is concerned, especially when we look at complex nexus of individual, personal, social, family, and environmental influences as an outcome or as determinants of adolescents' mental health. And these factors are really important because these factors, they actually determine adolescents' identity, and they actually help them to adapt and to cope in a given situation. If we look at specific research evidences in Pakistan, there are a lot of recent studies, and we have demonstrated evidence to establish relationship between parental upbringing and emotional support in terms of examining adolescents' mental well-being, because this is something that helps them to manage stress and to develop resilience. And there are evidences, quite recent evidences, where parenting styles are positively correlated with different mental health related outcomes. And as far as a study conducted in 2021 is concerned, they talked about that adaptive parenting is something that we need to get adapt to depending upon developmental needs of children and depending upon situational demands. And we do have empirical sport in context of Pakistan when it's about relating family sport as a key mechanism to determine adolescents' mental health. So carrying on, I think it's very important to briefly explain the contextual background of this study. We have a sample specifically taken from Mirpur Azad, Jammu and Kashmir. Mirpur is is a region where there's highest rate of immigrants as far as Pakistani demography is concerned. They do have their own president, they have their own prime minister, they have their own administrative administrative like setup, but they are Pakistanis. As far as the kind of like socio-cultural system that is prevailing in that region is concerned, we have to understand that most of Mirpuri's population, they do hold dual nationality, and they have emotional and family ties abroad. And this may influence the kind of socio-cultural environment in which they are living in. And they do have very strong connections and emotional and family ties with people living abroad, as compared to when we do compare the demography of this particular region with our other provinces, including Punjab, Sindh, Khyber Pakhtunkhwa, and Balochistan. And it's dominantly influenced by this area, or the people who are living here, they are dominantly influenced by Western values. And they have a very strong emphasis on education and future aspirations for international migration. More than 70% individuals at primary level, they are enrolled in schools and in colleges. As far as like general social system is concerned, they do have a tribal brotherly system where people, they're living together. There is not much ethnic diversity. As far as general population is concerned, they have a local language, which most of people do own. And ethnically, they are not varied people. They're known as Kashmiri or Pahari people. They do have a hybrid identity, which is being influenced by Eastern and Western values. So based on this, we are assuming that youth living here, they are probably facing unique psychosocial challenges, which probably are different, the kind of socio-cultural environment we do have in major provinces like Punjab, Sindh, and other provinces as well. As far as existing data is concerned, we have studies and data spotting from Punjab province. But as far as this particular region is concerned, there is no as such published research. So this is the reason that we are aiming to initiate a qualitative analysis in order to investigate the cultural aspect that is very much dominant in terms of determining adolescents' mental health. So as far as our cross-sectional quantitative survey is concerned, we have a strong theoretical base coming from transactional theory, which talks about a mutual relationship and mutual sharing of experiences between parents and adolescents. And based on this integrated approach, we are trying to unpack the complex interplay of individual, personal, social, emotional, and family-related contextual factors in terms of explaining their mental health-related issues. If we look at existing gaps in our literature, there is strong need for culturally informed approaches to address mental health issues in our part of the world. And most of time, people, they are relying on Western models, and especially when it comes to using measurement models for assessing different mental health related variables is concerned. Most of time, people are using like English versions of different Western models. And in this particular study, we have adapted different scales in our cultural aspect. And we went through rigorous Urdu translations, and then we thoroughly examined content validity of all these instruments before going into the field. And this is an overall flow chart of our study. We started with initial translation and validation procedure. And for this, we had a very small sample size with 60 individuals. We conducted this basic translation and validation. And then we went through complex factorial validation of all of these scales on main study. During main study, we employed boys and girls, about 410 individuals we employed who were registered in different private and government schools. And then we performed different multivariate analysis to see initial trends in our data set. And I think it's very important to quickly go through operational definition of these variables, how we are explaining parental styles. We assessed parenting styles on basis of three main domains, that is authoritative, authoritarian, and permissive parenting. Authoritative parenting, such kind of parents, they're high on both responsiveness and demandingness. Authoritative parents, they are warm, nurturing, and sportive. They do set clear rules and boundaries for their children. They foster independence. They do encourage open communication, and they provide reasons for different rules within their family instead of solely relying on punishment. On the other hand, authoritarian parents, they are low on being responsiveness, but they are high on demandingness. Authoritarian parents, they are strict, controlling, and they're very directive. They do emphasize obedience, they enforce rules with punishment, and they do expect unquestioning compliance from their children. As far as permissive parenting is concerned, they're high on responsiveness, but low on demandingness. Permissive parents are indulgent, lenient, and non-directive. They are, most of the time, they are warm and affectionate, but provide few rules or structure, which actually allows their children to consider freedom with minimal consequences. As far as family functioning is concerned, we defined it in terms of pattern of family communication, roles and responsibilities within family, problem-solving strategies in family, emotional support received given by family members, and the overall atmosphere within the family. We used DASS instrument to assess depression, anxiety, and stress scale. As far as personality traits are concerned, we assessed big 5 personality trait factors, including openness to experience, conscientiousness, extroversion, agreeableness, and neuroticism. In terms of personal vulnerabilities, we specified this variable in terms of level of self-esteem and social support received from individual, family, friends, and peer groups. This is the detail of research instruments being used in this study. And you can see we have used Urdu adapted translated versions for each one of these measures. We used parenting scale, multidimensional family functioning scale, adolescent personality questionnaire, child and adolescent social support questionnaire, DAS scale, and then Rosenberg self-esteem scale. This is the overall demographic conceptualization of our sample size. I don't know if this is visible or not, but perhaps I'm unable to see how to, change its width.
F5.
So, yeah,
F5.
F5.
Yeah.
Dr. Anila, I'll quickly remind you as well, you've got
Okay.
four minutes.
Okay, fine. I'll manage within these. In terms of hypothesis testing, we came up with very unique findings, which I would like to share. That in terms of a parenting style, authoritarian and permissive styles showed significant differences. Then in terms of family functioning, interestingly, all of family functioning subscales were non-significant for this particular sample, and there are a lot of reasons behind. And as far as different personality traits are concerned, we found a significant difference on most of traits except for agreeableness. And then in terms of self-esteem and social support came as the strongest predictor of adolescents' mental health. And in terms of, digging out something really important for future research, I think it's important to highlight that we have to understand the complex role of personality traits. And then probably we need to see why family functioning is not as significant as it appears to be. And there are a lot of factors behind it. There are different empirical evidences supporting that family functioning might not be an important factor. But I believe that in our next level study, where we would be investigating qualitative inquiry, we might have some interesting dynamics as far as a family functioning variable is concerned. And the scales which were translated as part of this study, they are available for public and for open use, and especially for clinical and non-clinical population. As far as journal contribution of this study is concerned, I believe that this study would be helpful for identifying risk factors and relevant intervention strategies for this particular age group. And it would help parents to have a deep insight about their parenting techniques, because there are no formal institutions. And as far as journal curriculum is concerned, there's no information about gender, there's no education on parenting and marital roles. This is what we are lacking at, especially as far as our curriculum system is concerned. So as part of our ongoing research, we are extending our study to initiate a complex SEM model testing, and then we are on way to develop a parental training model. And these are few of the references which were used in this presentation. And I'm really looking forward to have suggestions and comments from our audience. Yeah, thank you.
Thank you, Dr. Anila. Very, very informative. I had no idea about Mirpur. So much learning that within Pakistan, there is a place where, they have their own systems. And so thank you and good luck with this work. If people have any comments, questions, they'll put it in the chat box. Thank you very much. And thank you for finishing time as well. Over to
Thank you.
to introduce our next speaker, Andrew.
Thank you, Nazim. Yeah, our next speaker is Professor Mary Dozier, and Mary is a Unidel Amy E. DuPont Chair and Professor of Psychological and Brain Sciences at the University of Delaware in the United States. She has studied the development of young children in foster care and young children living with neglecting birth parents, examining challenges in attachment and regulatory capabilities. Along with her graduate students and research team, she developed an intervention, Attachment and Biobehavioral Catch-up, or ABC, for parents of vulnerable infants. In 2016, she was named the Francis Allison Professor, the university's highest faculty honor. In 2018, she received the International Society for Infancy Studies Translation Research Award and was the recipient of the American Psychological Association Urie Bronfenbrenner Award for Lifetime Contribution in Developmental Psychology in the Service of Science and Society. Mary, we're very pleased to have you. Please go ahead.
Thank you, Dr. Andrew, and thanks for that wonderful introduction. Let me just pull this up and get my, share my slides. Are you just seeing the PowerPoint now? Okay, thank you.
Yes.
Wonderful. Well, thank you so much for having me as part of this conference. I am honored. I'll be telling you a bit about attachment and biobehavioral catch-up, or ABC, and this is premised on parental sensitivity really being key to our development. We're an altricial species, meaning we're highly dependent on parents when we are babies, dependent on parents as both protectors, but also as responsive partners. And these are key things that are integral to developing attachment, developing brain connections, developing adequate emotion regulation and behavioral regulation. And when young children lack a responsive caregiver, there are effects on brain and behavioral development. And I'm going to show you here a picture of video of a mom and a baby in a motel room in Delaware. She's given me permission to show this, but you can see that this baby looks like an orphanage child because she's just not engaged with the world. She's got 8 months old. You would expect of an 8-month-old, just very listed. And don't be discouraged because you'll see this baby again at the end of the presentation. But infancy and early childhood represent a particularly important time then for intervention. And ABC targets then 3 things: nurturing the distressed child, following the child's lead when the child's not distressed, and then avoiding frightening behaviors. And we do this through 10 sessions in the home. I want to mention that these photos are from a collaboration in Dhaka, Bangladesh, with Dr. Famida Tofail and Johanna Beck at the University of Houston. So the first target for us is nurturance. Nurturance is key to the development of an organized attachment, but there's 2 things that can get in the way. One is that children may push their caregiver away. And if we had longer, I would show you evidence of that, but trust me on that. And second, nurturance just doesn't come naturally to everybody. And so what we do in ABC is that we encourage parents to provide nurturance even when the child does not elicit it, and even when it doesn't come naturally for the parent. We do this in 2 ways. We have a manualized curriculum. Keep in mind, it's 10 sessions. But we also make in-the-moment comments, and we know these in-the-moment comments are key to change. We make comments once per minute. And here's an example. A fussy baby. Mom is probably tempted to put this baby down, but you can see.
Okay. All right, honey. We're almost done. Okay.
So this is the kind of comment we make every day. We make it in very specific ways. These comments can have 1 to 3 components. Describe the parent behavior. He's crying and you're holding him, so she knows exactly what we're talking about. Link it to the intervention target. We're talking in an abstract way about nurturance, but here it's good job nurturing him because it then instantiates it. It brings it to this particular behavior, and then linking it to the child outcome. That lets you know you're there for him, or that's going to help him develop a secure attachment, or that's going to help him be able to have friends that he can count on when he gets older. These are evidence-based outcomes that we mentioned. The second component is following the child's lead. And so why that? Well, we know that when early adversity leads to biological and behavioral dysregulation. We know this for non-human primates and rodents, and we know it for humans. And the HPA axis, the hypothalamus pituitary adrenal axis, produces cortisol, and cortisol is then an end product and sensitive to the experience of adversity. And there's 2 orthogonal or independent functions of the HPA axis. One is a stress reactive function that I'm not going to talk about, but is one that people are usually more aware of, is that our bodies mount a stress response. Giving a talk like this is something that leads people to mount a stress response. But there's this other function that's independent of that, and that's maintaining a diurnal function, that when we wake up in the morning, we have this high level of cortisol. It peaks about 30 minutes after we wake up and comes down to near zero level at night. Now, this is one of those, temperature also has a diurnal function, but this is one of those things that's leading me to be more alert and alive and awake, probably, than some of you, where it's 8 or 9 at night, where your cortisol should be getting low and allowing you to be able to go to sleep at night. And so this doesn't reflect more stress in the morning. It reflects the metabolism of glucose. This is our body's cup of coffee in the morning that helps us be diurnal creatures. So what we found among low-risk children is that this nice high morning value of cortisol and a low evening value of cortisol. When we looked at children in foster care, we saw a flatter pattern, lower in the morning. And when we looked with children in neglecting birth parents, we found the flattest pattern of all, lower in the morning, flat across the day. So he said, boy, we got to somehow change this physiological dysregulation. And we also knew we wanted to change behavioral dysregulation. And so what we reasoned, and this took us a while to figure this out, but is that when parents are more responsive, children develop better regulatory capabilities. So we were going to help parents be more responsive to their children. And by that, we call it following the lead. Other people call it contingent responsiveness or serve and return. We call it following the lead. And look at this dad following the lead and notice how attentive this child is to his interaction. He's just following the lead with his word, but still following the lead. And
what do you got in your hand?
And in the interest of time, I'm going to just show you the same child real quickly with a mom who's not following.
Blocks?
And notice
Blocks.
how uninterested this child is.
Looks
This
green.
is, you can imagine it's not very regulating, but also the child's not going to develop attention
Can you count
as
two?
well as when the parent's following the lead. So we do the same thing. We have our intervention manual, but we also make comments in the moment. And I'll show you this real quickly.
Thank you. You want it back? There you go.
And that's perfect. Like little things like that, we're talking about responding to baby signals, and even just reaching out for something and you giving it to her, that's going to make her feel important and like she can have an effect on things around her.
Okay.
So I show you those comments just to give you a feel for them. But again, we make those once per minute. So it's a very active intervention. Only 10 sessions, but you're making 60 comments in 1 hour. And the third component is avoiding frightening behavior. And what we know is that frightening behavior undermines a child's ability to regulate behavior and biology. And so we address this in a somewhat different way. If there's time, I'm happy to elaborate on that in comments later. But to assess the effectiveness, we have conducted randomized controlled trials, and people at other places have now started to also conduct randomized controlled trials and have similar sorts of effects. So what we're looking at is children who are neglected. I'm going to tell you about Child Protective Services involved. So these are children who have been recognized by the system as having significant, or parents as having significant problems. And we randomized to either ABC or to a control program that looked very much like ABC in terms of its structure, but it didn't focus on nurturance and sensitivity. So what we posit is that making these in-the-moment comments as our active ingredient, that leads to parental sensitivity and nurturance, and then that's going to lead to enhanced child outcomes. So what's our evidence of effects on parental sensitivity? We find that making more of these comments leads to greater changes in parental sensitivity. And we find that we get medium to large effects in sensitivity in randomized controlled trials, and we see these same effects 3 years later. And we see this in every RCT we have conducted, and others have as well. And so what are the effects on attachment? We know that adversity makes it more likely that children develop insecure or disorganized attachments. We look at this through the strain situation, which is a series of separations and reunions, and then we code these. And what we find is that more of the children in the ABC intervention have secure attachments compared to children in the control intervention. 52% have secure attachments. In a low-risk sample, you expect about 60%. So 52% is really quite impressive. And fewer of the children have disorganized attachments. And I'm sorry I don't have time to explain more about what these look like, but you really want an organized and secure attachment. And then we see, to me, this is shocking. At age 9, 8 years after the intervention, we ask children, how much can you trust your parent? And ABC children say they can trust their parents more than children in the control intervention. And the same thing at age 14. This is 13 years after a 10-session intervention. So ABC looks much more like the low risk and significantly different from the control. And I'm just going to say this very quickly. We did MRI assessments where we put children in a scanner at age 9, and again at 13, 14, 15, but those data we're still just looking at now. And what we're looking at really is the difference between how they respond to their mother when they see their mother's faces and when they see a stranger faces. But we ask them to push a button when they see a happy face. And the overall finding here is that ABC leads to changes to the midline brain structures that are involved in complex social reasoning. And so what we think is that ABC is really affecting the brain in ways that help children enhance better social cognition, and therefore emotion regulation. So ABC effects on physiology. We remember that this is what we wanted to change. We want this to be a steeper slope, higher morning value. And what we see is indeed higher morning for ABC right after the intervention. And if we look at them 3 years later, again, we still see this steeper slope. This better supports kids being awake, alert, involved in the morning, better able to deal with what they've got going on at school. So next, behavioral regulation. And we didn't remember, all we're targeting is nurturance and responsiveness. We're not targeting any behavior management sorts of things. But a child's ability to sit quietly in school and attend is more important than knowing their numbers and letters or just about anything else in terms of school success. So what we do is we give children this wonderful array of toys and say, don't.
Now remember, when I'm doing my work, don't touch any of these toys, okay?
And this child, you'll just see a beautiful ability to inhibit the desire to play with those wonderful toys. And this may seem a little cruel of us to do to a child, but I think this is what preschool and kindergarten is. That these are the demands of preschool. All these wonderful toys around in your ascot. And so what we see is that fewer of the children in the ABC program touch the toys than children in the control intervention. They take longer to touch the toys, they touch them less. So I've run through these very quickly, but you can see we have impressive effects in infancy across attachment, DNA methylation, cortisol, early childhood, of things I haven't gone into, language development, something we certainly didn't expect, but now makes all the sense in the world. Middle childhood, I haven't gone into autonomic nervous system regulation, and some of the brain activity findings. And then adolescence, this list is shorter just because this is what we're just now looking at right now. We're just getting those data. And often when you take a program and implement it in the community, you lose your effects. But we see effects in the community as we implement this in 8 different countries that are just as big as what we see in our randomized control trials. This is on a 5-point scale. 3 is what we consider adequate sensitivity. And before the program, mothers well below this adequate sensitivity, after ABC, well above that. And here, drops in intrusiveness. 1 is as low as you can go, and you can see they're approaching that. And what's exciting to me is that this work, a pilot in Bangladesh, we see effects that look very similar to what we see in our lab. And we can talk about cultural adaptations. We made surface level cultural adaptations that were quite important, including videos, translation where necessary. We were able to implement this in English, but the language. No, actually, we adapted that, so we did translate. Now here's that child. Remember the child who was totally withdrawn, not engaged. This mom continues to live in a motel room. We did not change that. So the children continue to live in a motel room with 3 children in a tiny motel room, but their world has fundamentally changed because their mom has become engaged with them.
Well, I don't love you much, do I? Just more than human tongue can tell, and that's all. See how it sparkles in my eyes. I couldn't hide it if I tried. That's right, I don't love you much, do I? Just more than anything else in this whole world. Just more than anything else in this whole world. Well, I don't love you much, do I?
So this is the book that Kristen Bernard and I have written about this program. This is my email if you want to get in touch, and our website. And let me just call attention to, I am sorry that I did not recognize that my name was misspelled in the program. So if you want to get in touch with me, please note that it's D-O-Z-I-E-R, not D-O-S-I-E-R. And I don't know, do we have a minute for questions or not, Andrew?
Yes, we do. Yes. Rabia, is there anything in the chat box, or do we ask people to put up their hand?
No, Andrew, not in chat, but we can ask if anyone wants to. Yeah.
So if anyone has a question. Yes.
Can I ask
go
a
ahead.
question? Yes.
Yep.
Excellent presentation. Very, very interesting. You've talked about Bangladesh, and you said other than translations, some adaptations were required. Are you able to say what those adaptations were?
I would say in general, what we are finding, what I would argue for, but also what we're finding is that these concepts are universal. They may be at odds with normal cultural practices, and they are in almost every culture is the interesting thing. But the need for nurturance and the need for responsiveness, I will argue, is there across cultures. And so our adaptations at the surface level are in terms of the kind of toys that we provide, the words that we use. I mean, it may not translate directly when we say follow the lead. Germany, follow the lead meant something very noxious. It meant something very Hitler-like. And so being cautious, careful with the language. And so working very closely with people in the local context. And in this case, we're just so lucky to have a champion there with Dr. Famida. I just feel so fortunate to work with her because she has, in 6 months, I've never seen anything this fast. She has translated, she's implemented, she's got pilot data in amazing fact. I have never seen anything so impressive. So they're what I would say, and then what we're going to want to do after that pilot is think carefully with parents and with parent coaches, what else do we need to do? So we're in the process. But when I say surface level, I would say the concepts worked very well. It's the particular language, the particular activities we ask parents to engage in that don't matter really. It's really how do you get at giving parents practice and following the lead or nurturance.
Very impressive. Thank you very much.
Thank you.
Well, Mary, this has been a wonderful and inspiring presentation. And it's no wonder to me now that you've had so much recognition and so many awards, and best wishes in your continued career. And thank you so much for this fine presentation.
Thank you. Could I just ask that the folks at the University at Equa put theirs in the chat so that I can respond? I don't want to neglect that comment.
Yeah, Mary can put your comments in the chat, and then
Appreciate
Mary can get back to you. Thank you for that, Mary. Appreciate that.
Sorry to interrupt you.
No, that's fine. So now we're going to take a break for about 10 minutes. I should say 10 minutes. And that was an authoritative statement about making a 10-minute break, not authoritarian. And we'll come back, and our speaker will be Dr. Mina Hussain, our first speaker, after we come back. So have a break, and we'll get back in 10 minutes. Thank you. And while we're just disbanding here for a little bit, I want to recognize Anne Schwischau from ADRA, Vietnam. Glad you're with us, Anne. And Devani from Chennai, India, Balamundir. And I noticed that Kim Long Tri from ADRA, Cambodia is here. Welcome, Kim. Glad you're here. Okay, see you in 10 minutes.
Thank you, Andrew. Nice to see you.
Yeah. Maybe
Okay.
Rabia. Can Rabia help out there?
Screen there. Does that,
There.
can you see that?
Yes. Yes.
Okay, great. Thank you very much. Okay. So yeah, thank you for that very warm introduction. It's a pleasure to be here again and to be part of this important area. So today I am here to talk about a deeply important topic. I'll be presenting some work about an integrated parenting intervention for parents with schizophrenia, and I'll be presenting some findings from a feasibility randomized controlled trial in Pakistan. So again, thank you for that introduction. Just a little bit about my background. I'm an inpatient psychiatrist in Toronto, and I also work across a couple of other different settings in the emergency department and in a crisis outpatient clinic. So day to day, much of my clinical work is mostly around severe mental illness, and those are the majority of my clients. So day to day, I come face to face with people who are struggling with severe illnesses like schizophrenia. And last year, I gave a talk about supporting patients with severe mental illness and who are parents on an inpatient unit. And this is what sparked a deeper interest and commitment in me to explore how we can better recognize, support, empower parents with severe mental illness. So I'll be talking, as I was saying, I come across a lot of patients with schizophrenia. So today I'm going to talk a little bit about parenting and schizophrenia and why this is important. So schizophrenia is a complex, debilitating illness. It is in the top 10 causes of disability in those aged 15 to 44. And often what happens is that around this age group, what we focus on a lot in the inpatient setting, at least, is how to get these people back into employment. But as you can see, 15 to 44 is also a very important time in terms of people's reproductive years. So we see lots of people with schizophrenia who are also parents, and what can happen is this can often get overlooked. But we know that even in the most healthy of circumstances, this is a very, very difficult time. It's a period of enormous transition. There are things like often what happens is people's sleep is interrupted. There are enormous responsibilities in terms of being aware of the child's development, things like breastfeeding. Lots of things are going on around this time. So there are huge challenges for parents. And they say even in the healthiest of circumstances, it takes a village to raise a child. So you can just imagine that in this group of people, there's the added burden and the added stress of dealing with such a severe illness. Dealing with the symptoms of things like paranoia, withdrawal, hallucinations, delusions, and on top of that, having these other parenting responsibilities. Yes, so there is huge gaps in support. In terms of the support that's available, we see a lot that's been done around maternal depression. Parenting interventions for maternal depression is that there's been extensive research around that now. Paternal depression as well and anxiety, those are now being looked into. But in this region, there is very little work that has been done around supporting individuals with schizophrenia who are parents. And we know there's been research that shows, it's been widely accepted, that the children of parents with psychosis, they do suffer academically, emotionally, socially. And this is not just from the illness itself, but it's also the added difficulty of stigma that's attached to this illness. So let's talk a little bit now about the local context in Pakistan where this study is being done. We know that in Pakistan, stigma plays a huge role in people becoming disengaged from the services. So stigma and a lack of education around mental illness is it's been identified as an enormous barrier to care. And what can happen is that people can end up concealing their illness because of fears around being rejected from their society, being rejected from their family, from their spouse, from their neighbors. And there is a big element of shame as well that plays a part in this. So what we need is, we urgently need culturally adapted, low cost, practical support for this group of individuals and families. So we'll talk a little bit about the study that's being done. So some of the goals of this study is to assess whether the intervention is acceptable to parents with schizophrenia, to determine the feasibility of delivering the intervention to this group, to identify appropriate outcome measures for a future trial, and to explore barriers to recruitment. So we have been working across 4 major cities in Pakistan. The cities are Karachi, Hyderabad, Lahore, and Rawalpindi, in collaboration with hospitals and psychiatric units. So a little bit about the inclusion and the exclusion criteria. Participants include both mothers and fathers, aged 18 and above, with a diagnosis of schizophrenia spectrum disorder, who have been stable on medication for at least 3 months and who are caring for a child aged 0 to 3 years. And we have excluded individuals with active substance use disorders to maintain the fidelity of the trial. Okay, so I'll talk a little bit about the intervention. So this is a two-pronged approach. The first part of it is a parenting intervention, learning through play. This intervention has been tested extensively in the area with maternal depression and has been found to be effective. It is a parenting program that uses a pictorial calendar to guide parents through the stages of child development. And it focuses on things like everyday bonding activities, and it focuses on like 5 key domains. And the beauty of this intervention is that it's not text heavy and doesn't include a lot of jargon. It's very visual and simple and pictorial. And it can be used for large populations with low literacy rates. The second part of this intervention is focuses more on supporting the parent's own mental health recovery. So this is a culturally adaptive cognitive behavioral therapy for psychosis, so CACBTP. And what this does is it's an individualized therapy by trained psychologists, and it uses strategies to support individuals with their symptoms like hallucinations, delusions, thought disorder, and negative symptoms, alongside some tools to support them with relapse prevention and insight. Okay, so a little bit about the procedure. So we're screening participants using the PAN scale and also the eligibility criteria. And they'll complete their baseline assessments, and then these individuals will be randomized into the treatment as usual group and into the intervention group, and there'll be follow-ups at 3 months and at 6 months. And a very important part of this study is the qualitative interviews, which will be conducted with the participants to get their experience of the intervention. And the number of this will depend as we go. So these are some of the outcome measures that we'll be using. The PAN score scale, as I mentioned, and here are some of the other outcome measures that is going to be part of the study. So just a little bit about the study progress. So the number of patients that have been approached so far, there's been 162 patients, and the 85 of those patients have met criteria. Out of those, 28 have withdrawn consent, so that leaves us with a total now of 56 patients who've been randomized. 28 have been part of the treatment as usual group, and 28 is part of the intervention group, and then there's been 3-month and 6-month follow-ups. Okay, so that was a little bit about the study, and I just wanted to highlight that my area of interest has, as mentioned in my introduction, has been around promoting awareness and using the creative arts as a tool for engaging the public and reducing stigma. So I work as an inpatient psychiatrist, and I come across day to day, I've come across patients who have schizophrenia, and I've had the opportunity to sit down with them to talk about some of their challenges, in particular around parenting. And what we found is that there's very little, even over here in Canada, very little support that people are aware of. And so what I do is part of my role is producing short films. So I have produced short films around mental health, which have been shown in Pakistan, in Canada, and in various different film festivals, in public engagement events. And the aim of these films have been to reduce stigma and to get people signposted to the correct supports. So interestingly, we had a very nice nationwide tour around Pakistan with one of our first films on psychosis. And what happened over there was that we created an environment where people could come, share their stories, learn a little bit about the illness. I'm going to show you a clip about that, just about that movie now. We're able to talk about some of the challenges that they had in a very safe and contained environment. So we're working at the moment on producing a short film around this particular topic, and to have a safe space, because as I mentioned before, stigma is a huge barrier for care. What we're also doing, before I show you the clip of this, is on my inpatient unit in Canada, is that we are preparing some information leaflets for patients who get admitted to the inpatient unit. So as I've mentioned before, and in my talk previously, there's lots of different challenges that come in here. There's the stigma, of course, that people feel. There's the guilt. So what these leaflets and these tools are going to do is offer people practical strategies to keep in touch with their children. So things like video calls. We are working on providing people having their children come to the unit and have a safe environment in which they can speak to their children, have certain ways in which they can explain their illness in an age-appropriate way. And what we want to do is we want to encourage this. We want to support the parent, of course. We want to support families, which is a huge thing as well, especially in cultures like in Pakistani cultures, families are a big part of it, to get them involved even during their hospital stay, and develop the tools so that we can provide a way to work together, and so that these parent-child interactions are positive. And we want to empower parents to maintain their goal as caregivers, their role as caregivers, and to eliminate or to reduce some of those feelings of stigma and shame. So I do want to share, I hope that this works, I do want to share a clip about a short film that I produced around psychosis. This is not for psychosis in parenting, but it's psychosis in general. So it'll give you a little bit of an idea as to how some of our work looks like, and some of the impact that it can have. So I'll just play that. Are we able to hear that?
Not yet.
Is that?
We see your screen, or at least the.
Can you hear that?
No.
Share the computer sound at the bottom right. Under more.
Is that more on Zoom? More. I wonder if, Rabia, I've sent you that. I wonder if you can play it.
Sure. Just give me a second.
Sorry?
Pakistan
Yes,
is
okay,
again
but
coming to
I'm
the screen.
sharing. Just a second.
In the meantime, Meena, you can talk about where it's been screened. Any comments, anything about the film?
Yes. So these films, I mean, this film was made in 2018, so it's been a while. We've had subsequent films that have come out since then. And it's how we usually do this is we start off by going through the film festivals and having our world premiere there. And then it's been shown in film festivals in various different countries around, in the UK, all around Europe, in North America, various parts of Asia, and in Africa. And what we did find through that process was that though this is a story that's specific for Pakistan, some of the themes that came out with this, what we found was that they resonated with audiences around the world. So, what they were saying in the last talk as well is that, though we do culturally adapt, a lot of these themes are universal. We show them as part of training events for the residents at our training program. It was shown at the Maudsley training program as well as part of their training. And various other different public engagement events. It's been shown to high school kids, which was interesting. They actually had a lot of questions around the illness. And we've had more appropriate films as well to show younger audiences. So even as early as there's material that we've made to show as early as individuals in primary school.
I think Rabia is, yeah, she's come now. Yeah, let's see.
Can you see?
Yes.
Can you start it again? We can't hear.
Sorry, Dr. Manna?
We can't hear it. Can you start again?
Okay. Let me share.
You have limited time.
It's just 1 minute.
Please check now. Can you hear now?
Yeah.
Yes. Well,
क्या आपकी बेटी 5 वक्त की नमाज पढ़ती है? खुदा इसको फैज़याब नहीं कर सकता इंसान को जब तक उसका अकीदा मजबूत ना हो।
मरियम, खुश रहोगे इंशाल्लाह। लड़का कितना शरीफ है ना?
बाजी, किससे बात कर रही हैं? किसी से भी नहीं।
क्योंकि सिर्फ मैं तुम्हारे बारे में सोचती हूँ, सिर्फ मैं, और कोई नहीं।
आपको किसी की आवाज आई थी पर नहीं ना? मुझे
तो प्यार करती हो?
हाँ।
okay. Are you finished there, Nina?
Yes. So that's. I just wanted to finish off by showing a little bit of just some of the work in that area, and yeah. So I'll just.
Well, that's a
Yeah,
powerful
there's no more
combination.
slides anyway.
Yeah,
So,
there's
yeah. Thank you very much.
Powerful combination of research and promotional work that you're doing. I don't know whether that's unique, but I know that when you presented earlier, you were working on this, so you've been doing this now for a number of years. Well, best wishes as you continue. You pick some very difficult work areas and some powerful tools to make things, to share those and promote those. Thank you very, very much, Mina. Well done, and we'll look forward to hearing again from you in other years. Yes.
Thank you.
Okay. And Naseem will introduce our next speaker. Naseem?
Dr. Naseem, you are mute. You are mute.
Sorry. I was saying very, very excited to introduce our next speaker, Dr. Yolanda Fountain, who has worked in the mental health field, helping infants, children, adults, and families overcome life's challenges. She's been working in this area since 2006. She's a licensed counselor in the states of Georgia and North Carolina, a play therapy supervisor and trainer, a SAND therapy consultant and trainer, a mental health forensic consultant, a registered neutral mediator, and a 0 to 3 fellow. Dr. Fountain is the owner and executive director at Play Wellness LLC in Roswell, Georgia, and the founder of the Child Loss Center, Inc. She also serves as a board member for the Association of Play Therapy. Dr. Fountain, looking forward to your presentation. Welcome, and over to you.
Thank you for having me. I'm going to drop in the chat box the handout for today and also an article that you can feel free to read that's related to what we're talking about today, which is playful parenting, by the way. So I'm going to drop those two and then I'll start the PowerPoint. Just for your reading pleasure later, if you'd like. I'm sorry.
I said thank you very much for this. I'm sure people will find
Oh, you're welcome. And I see the university in Karachi. Hi. All right, so I'm going to share my screen. Let me just share this. Give me one quick second. Let me make sure I enabled the meeting. Okay, it's not giving me that one. Okay, can you all see this okay?
Yeah, we can see your screen.
Okay, great. All right. So thank you for the introduction. I love what I do, which has led to several credentials, but they all relate to infants, children, parents, and families, because that is where I enjoy prevention, and I do provide some reactionary work, but I enjoy prevention in those areas. So we're going to briefly and quickly just explore how we combine and what is play in parenting all about. We'll look at what's play therapy and then explore a few play therapy activities based on what we can do. I kind of pick quicker ones, so hopefully they'll go by pretty quick just to kind of give you an idea. So when we think about parents and play, if you would, in the chat box, if you have had an opportunity to play with your own caregiver, so your mom, dad, or whoever cared for you when you were younger, what do you remember about playing? What did you play? If you could put that in the chat box. I know at Karachi, if y'all want to unmute and share, you can feel free to do so. And if you did not have any opportunities to play as a child with your caregiver, you can simply put no in the chat box or not respond at all. It's up to you. My Zoom controls have stopped working, so I'm unable to open the chat box for some reason. Let me see.
Maybe if you can stop sharing and re-share.
Okay, we'll try that. It won't even let me click the Maybe that fixed it since it voluntarily kicked me out. I'm back. Okay, one quick second. All right. Let's try this again. I'm going to go ahead and open up the chat box, and hopefully y'all had a chance to do that. Okay, here we go. Now I can see, although whatever you typed, because it kicked me out, I'm only seeing what's coming through right now. So I do see board games. Someone can feel free to share what was posted prior to, but all I see is board games. Hide and seek, dog in the bone. I haven't heard of that one. That's interesting. What did you, was there a consensus? Can you tell me if there was a consensus with play or not as much play with your parents? Anybody can do a summary of the chat since I missed it. Nobody's saying anything.
Hi.
Football, okay.
So this is Dr. Manaja. I can't see any of the other messages other than just.
Oh, okay. Well, maybe it's just not me then. Okay. Well, that's fine.
Yeah.
Well, at least we have some people who played. In this picture, this is a picture of my mom and my nieces that we took to Disneyland, and they got to meet Princess Tiana. And this is kind of like a picture of intergenerational play. My mom doesn't know how to play as much. I grew up playing a lot. And so it's interesting because her grandkids love to play. So we all had a blast though together in encouraging play. So I would like to share a quick video on the reason why it's important to play. I don't want to seem culturally insensitive because this was recorded with kids from India. And I know there's current challenges going on between the countries, but it still shares a point that is done by Hasbro Gaming, which is they make a lot of board games. So I want you to see kind of how the children respond, if it will let me play it now that I think about it, because I didn't get the option to enable. Sometimes okay. Anyway, so the point of this video, I'll just summarize it. The kids were interviewed. They didn't know that their parents were watching them. The kids were interviewed, and they were like, "What's your favorite thing to do with your parent?" And all the kids had different things, but they all related to playing with them, having fun, playing games. And then they asked them, well, when do you get to play games and have fun? And the kids, all of them generally got this really sad look on their face. Well, they're always working, or I don't want to ask them because they don't have time, and the parents are like devastated because they see the expressions on their children's faces. And then when the kids are surprised by the parents being there and watching them, and they have time to play, they get really, really excited. So if you do get a chance, you can look it up on YouTube. It's #Time to Play with Hasbro Gaming. And I think they have like 2 or 3 of these. But it's a really cool, eye-opening experience to see how children respond when they can get some playtime with their parents. Unfortunately, when there is no play in childhood, or there's extreme neglect or abuse that prevents an ability to play, we also get into what's called play deprivation. And so research shows a couple of things, and that article that I posted in the chat box goes into more detail. And that was a recent kind of cumulative study as of 2024. And it included Eastern countries as well. but it showed impaired brain development and flexibility. There was an increase for abnormal development, as well as non-compliant and aggressive behaviors and self-injurious behaviors. It decreases their ability to engage in self-control, and it inhibits their social relating skills. It also reduces their sense of self-worth and sense of self-discovery. It lowers creativity and problem solving. And then from a mental health and or emotional standpoint, it increases anxiety, depression, feelings of helplessness, suicidal behaviors, and narcissism. And so, it's easy to say, oh, okay, well, play is important. But then when you look at all the things that can occur because there's an absence of play, it becomes more realistic in its application. So when we think about play therapy, one of the original definitions was by Virginia Exline, who wrote play therapy and kind of formalized its use in 1974 with her first book. And she said, play therapy is based upon the fact that play is the child's natural medium of self-expression. It's an opportunity which is given to the child to play out his or her feelings and problems, just as in certain types of adult therapy, an individual talks out his or her difficulties. And so the Association for Play Therapy defines play therapy as trained clinicians who use theoretical principles of play to assist children with psychosocial and other developmental areas. In play therapy, we consider the toys as the child's words and the play as their language. So literally, when we train clinicians how to engage in play therapy, they are learning a new language. They're learning the language of play. It does not depend on language, verbal language. We can learn and assess without any use of verbal language. There are benefits of play therapy and play in general. As you can see, a lot of them counter the challenges of play deprivation. So some of the cognitive benefits are brain growth and neuroplasticity development, imagination, creativity, which is counter to the play deprivation, executive functioning skills. Physically, it can boost physical activity levels, which enhances overall physical and mental health. And it helps with gross and fine motor skills, which is also a play deprivation if not provided. And physical and restful sleep, which is, of course, a huge regulatory on so many systems, including your stress system. It helps socially and emotionally as well with all of those things that you see listed here. I don't know if Dr. Ruth is on, but she shared a picture of Rumi graduating from pre-K. So I decided to throw that in there for your entertaining pleasure. And then this is Dr. Kelly McLaughlin Bell, who just had her baby. She was in our 0 to 3 fellow. And this introduces family play therapy theoretical orientations, and these are play therapy specific. So just note that. The first one is developmental play therapy, which is inclusive of first play. We use this with families who have infants and their caregivers. And then the next three are actually evidence-based by the Substance Abuse and Mental Health Services Administration, SAMHSA, in the USA. So they have been researched to show that they are proven. And the first one is TheraPlay, which is often used for foster and adoptive families, but can be used with any families that have more attachment challenges. There's also filial therapy, which I use quite often in the office, which teaches parents a certain set of skills to build a better relationship, attachment, and emotional regulation skills with their children. And then there's child-parent relationship therapy, which is known as CPRT, that's also evidence-based. It is a manualized version of filial therapy and typically can be used with groups of parents for 10-week sessions. And lastly, I just want to share what children learn in play therapy. So they learn to respect themselves, that their feelings are acceptable, to express their feelings, to assume responsibility for themselves. Apologies for that error in typo. To be creative and resourceful in confronting problems, to learn self-control, to gradually learn at a feeling level, to accept themselves and make choices. So this is my 2-year-old nephew who got this this bike, and at first he was afraid of it. He did not want to touch it. It was bigger than him. No. He ran completely away, the opposite expectation that we had. But then when he saw his older siblings and cousins go over it and enjoy it, he finally decided to get on top, even though it was much bigger than him. And so play can invite those wonderful changes. So we're going to look at a few playful parent partnering activities. This first one is just to get you oriented in your mindset. And so if I could just have a volunteer to unmute and share what you notice about this donut. We're going to consider this donut. What do you notice about it? Or you can put it in the chat box.
We have comments in
It's
chat
circular?
box. In
What did
chat.
you say? Oh yeah, it's circular. There's no color. Anything else you noticed?
We have one more from Professor Nusrat.
Too circular.
Yeah.
Oh yeah, I see it now. Okay, too circular. Interesting. So when you pick up a donut, go ahead. Empty. Okay,
yeah.
has a hole.
If I look at it very intently, maybe it is an optical illusion, but it's sometimes
You're very soft spoken. Hold on, let me turn my ear. Say that again.
I said if I look at it intently, it gives a feel that maybe it is not circular. There is
Oh,
some
maybe
kind
it's
of
not circular. Okay, so maybe there's some abnormalities
elliptical,
when you would usually see a circle.
elliptical or something like that.
Okay. So too circular, empty, it has a hole, no sweet confections, big hole in the middle. So you all kind of tapped into what this is a child parent relationship therapy exercise with that they do with the parents, because that is one of the common things that's pointed out is the hole in the middle, right? Sometimes we miss all of what we consider to be the goodness of the child because we're focused on the hole in the middle of the donut. And so what you get to do is decorate your own donut that's symbolic of your child, to show that even though there's this hole in the middle, which can be representative of some of the child's temper tantrum, some of the things that you prefer your child not to do. But if you focus on this hole right here, you're going to miss all of these beautiful decorations and positive advantages that your child has. And so it's a balanced view. How do we look at what our child is doing, what our children are doing well, and not let this whole become the whole focus? It's also important that we help children connect to their bodies, so that they get an understanding of what it feels like on the inside. So we're going to practice a belly breathing and progressive muscle relaxation exercise. So if you're comfortable, you can try to get as relaxed as you can in your chair. If you want to close your eyes, you can. If you prefer to keep them open, you can do that as well. And so just kind of feel if your feet are on the ground, feel them planted on the ground. And feel your back. If it's up against something, feel it being grounded in the back. So your feet are grounded on the floor, your back grounded in your chair, on your couch, wherever that may be. And then ground your hands on your lap so that it feels like it has a place to go. And what you're going to do is slowly take a deep, as slow as you can, breath in your nose. You want to pace it out. You don't want to go too quick in or out. So pace the breath in your nose and then slowly blow it out of your mouth. You can go at whatever pace you like. So for example, if I go in my nose, and blow it out of my mouth. You just want to center yourself. You don't want to hypervigilate. So don't do it too fast or do it too slow. Just find the rhythm for you, and you can breathe in your nose, blow it out of your mouth. And then you are going to squeeze your toes as tight as you can, and then release. And just feel what your toes are telling you today. Are your feet tired? Are they feeling relaxed? And then squeeze your legs. So you can do upper and bottom legs and see what they're telling you.
Yolanda,
Have they
just a
been
quick reminder, only a
Time
couple
to
of
go. Okay, got it. So no, it's fine. So the purpose of that is that you can go through your entire body all the way up to your head. And this helps you realize when your body is tense and when your body is relaxed. And go ahead and take a breath in your nose and then blow it out of your mouth. We do that a couple of times, and then the activity. What this does is when children feel upset or anxious, the more they can get in tune with their body when they're calm, the more they'll recognize how their body responds when they're not calm. And same with the parents. The last activity I'll show you is called Color Your Heart, where you can draw a heart and then have a key coded section of different feelings and color in how much of your heart you feel. How much of those feelings you feel in your heart. So you can see here, there's a diversity of feelings, and there's more anxiety next to a little bit of overwhelmed and sadness in between mad and happy and scared. We're touching it. Quick quote here: you don't stop playing because you grow old because you stop playing. Here are my references and contact information. And any questions that you may have. I think I have a few more minutes.
Yolanda, we are over time, so people can put it in the chat box.
Oh, never mind. All right, put it in the chat box. I'll see you there.
Thank you so much. What an
Thank you.
interesting presentation. You've beautifully reminded us, Yolanda, that play is not just fun, it's foundational for child development. So thank you for doing.
Thank you.
Over to Andrew to introduce our last speaker for the day. Andrew.
Thank you, Naseem. We're delighted to have Dr. Torella Ike back again to present for us. As was mentioned, she's our final speaker. Torella is a senior lecturer at Teesside University in the United Kingdom. Torella's research interest revolves around forensic mental health, and she has published around this theme. Torella is also involved in co-leading evidence-based interventions using diverse methodologies, including randomized control trials to address psychological disorders such as postnatal depression, trauma, bipolar disorders, psychosis, suicide, and self-harm in a range of settings. Torella, we're delighted to have you back again to speak to us. Please go ahead. Is Torella
unmute? Okay.
muted?
Well, thank you
Oh,
very
okay.
much for that introduction. Hopefully everyone can hear me and see my screen.
Yes.
So today I'm going to be talking about an ongoing work that we are proposing to do, which is a parental intervention. But my emphasis will be a focus on the background work that we've done leading up to the proposed intervention, which is PC Care. So the title of my presentation will be Preventing Intergenerational Offending for Left Behind Families Affected by Incarceration Towards the Need for an Evidence-Based Parenting Intervention. So it's pretty much going to be building on the brilliant work and things that all of the speakers have talked about, the need for effective parenting intervention to foster that effective child upbringing as well. So just a bit of a background. Again, I come from more of a criminological background, so I'll be talking more about how this works within the broader body of imprisonment. So globally, it's a well-established fact that imprisonment is one of the most widely used system of punishment for those that might have been found guilty of committing an offense. So if we look at the World Prison Brief, which is one of the most authoritative databases that we have, you'd find that globally, approximately 11.5 million people are incarcerated. That is quite a significant number, considering the fact that when you incarcerate a person, it's not just that person that is being incarcerated, because sometimes some of those incarcerated are head of families, they've got children, they've got wives, they've got families that they've left behind. So incarcerating that person does have significant implications for those that are directly or indirectly affiliated with such a person. And again, coming from especially in low and middle income countries, like countries like Nigeria, where we have communal culture, the impact will be quite significant. Amongst that 11.5 million people, a significant number of persons are incarcerated are male, which comprise of 10.5 million people. And like I said, what the literature and database is showing is that a significant number of these males are actually breadwinner of their families, and that does have ripple effects on those that are left behind. So trickling it down to low and middle income countries, you find that approximately 7 million prisoners are from low and middle income countries. So from that number, we're seeing there 7 million and over 70 million are from low and middle income country, which is quite an issue of concern. That sort of gravitate towards approximately 70% of the world prison population. Then also narrowing that to the context of Nigeria, which is where, like I said, the empirical work sits. Nigeria as a country is with a population of over 230 million people, and not just that as well, it's one of the most populous country in Africa and does have significant position within the African continent. Based on data from the Nigerian Correctional Service, we have approximately 11 prison inmates, and that comprises of those that are awaiting trial, which form a significant number of this population, and other factors as well, with prison overcrowding and all of that. I know one of the key points that would be raised is why this statistic? Why is it important? And one thing I would say about this is that a really important concern about all of this is the impact of this incarceration on the left behind families, the adolescents, and including the children that again bear the brunt of the effect on their mental health, their well-being, and everything that has to do with their development. And also the fact that there is a significant gap in terms of the use of parenting interventions to actually address this urgent problem, which, to the best of my knowledge, seems to be given very, very, very limited attention, especially in low and middle income countries. And so, again, I'll talk about the systematic review that we did in the next couple of slides. But one thing I want to emphasize on is that when we think about imprisonment and incarceration, a lot of the work that have been done within the space tend to focus on things like the prisoners' welfare themselves, which in itself is great. But very, very, very limited attention is paid to the left behind families, who are often termed the forgotten victims of incarceration. So if you look at tons of the work that have been done, you'll find that lots of them focus on the prisoners. They look at things like poor mental health. So for example, prisoners suffering depression, anxiety, suicidal ideation, and all of those issues, substance use disorders among prisoners, or after they've been released, their post-release experience, issues of overcrowding within the prison context, stigma that prisoners and ex-offenders face when they come out of prisons, and I've done a lot of work in that space as well. Unemployment, bullying experience among prisoners. Again, these are something that I've been focused on largely in the literature. And then the issue of poor reintegration, which is something that is also something that bulk of the literature focus on. But there are very limited studies that actually look at the effects of incarceration and left behind families. And as of this moment, if you do a quick search, you will see that tons of the studies that you will find are either from the United States, which have 70% of the study, or maybe a few from the United Kingdom, but very, very limited studies looking at and then maybe a few from Canada as well, or other parts of the high income countries, but very, very, very minimal or little studies from low and middle income countries. So again, when we were thinking about this project and what to do about this huge gap that it represents, we're coming more from an Afrocentric perspective. So looking at how can we develop interventions, whether that's parenting intervention, whether that's already existing parenting intervention that's worked elsewhere, but bearing in mind the unique peculiarities of this population when we are thinking about the need for such a parenting intervention. Well, as researcher, especially considering the fact that I'm more of a evidence-based researcher that believe in a grassroots approach, which is the bottom-up approach rather than the top-down approach. So even if we do know that there is a huge gap, but we still need to follow all of the protocol to ensure that whatever intervention we're doing is grounded in the lived experience of these people and also sound research evidence as well. So to get onto this, we started off with a systematic review because at first, when I first of all did the literature search, I was shocked that there were very little or no interventions for families affected by incarceration in low and middle income countries. A lot of the interventions I was saying were in America and, like I said, on other high income countries. And for me, that was quite like a shock. And I was like, okay, how do we go about this? So collectively with the team, we decided to do a systematic review on this very important area. And again, the systematic review was registered, the protocol was registered in line with global best practice with the Prospero database. Because this is an area where obviously there is not a lot of interventions, we needed to understand what impacts incarceration have on these left behind families and what interventions are there to support with their mental health and well-being, as well as their social well-being. So that was the primary research question that the systematic review seeks to address. Then whilst we did the systematic review, we also then followed up with an empirical study. So again, the component I'm talking about is within the context of Nigeria. Similar studies have also been done in the UK for African Caribbean population, but I'll be focusing on the Nigerian-based study. So we did an empirical study to look at the lived experience of family members. So by family members, we define it to include, for example, the husband, the wife's spouse, and children, as well as siblings. They've got a family member incarcerated. And the reason why we adopt this definition is because unlike in the West, for example, in the UK, where we have like a nuclear family structure, in Nigeria, what we have is more like, and I think that's also similar in other countries as well, like Pakistan, we've got that communal family. So it's not a case of just the husband, the wife, and the children. There's also the external families, which could be the grandmother, the grandfather, the siblings, who also form part of that unique network of families. So we wanted to understand the lived experience of the impact of incarceration on them, as well as their parenting skills as well. So that was part of the aspects. So I'm going to be talking about the key findings from the systematic review, which has now been accepted for publication, and then the qualitative study, which will soon be published in International Criminology. So in terms of the systematic review, just a brief one of the key inclusion criteria. So these are the design. So we use the PICO model, again, in line with global best practice. So for example, the population, which are families, adolescents, children, carers, partners, and spouses. So that way we're able to get as many evidence that we can get in terms of the impact of incarceration or interventions for this population. And then in terms of intervention, we looked at both psychosocial interventions, whether there is, for example, CBT, whether there is any form of parenting intervention or any form of educational interventions for these families. In the context, we're looking at the context of mental health support, social well-being, and other impacts that are very much directly relevant to this population. So in total, we found around 21 studies that met the inclusion criteria. So more details are on the Prospero register if you want to read more about the inclusion criteria and all of that. And also, like I said, the paper has been accepted for publication. And if you're interested in reading the full paper, that will be made available as well on request. It's going to be open access anyway. For the empirical studies, again, for this one, we obtained ethical approval from Teesside University, which is where I'm based. And in terms of the design, it was more like a case study design because we're looking at left behind families that are affected by incarceration, obviously underpinned by a qualitative approach. And in total, we had 22 participants that took part in the study. So 13 of them were males, while the other 9 were females. All of the interviews were recorded, transcribed, and then analyzed using thematic analysis from an intersectionality theoretical lens. And the reason why we use intersectionality as propounded by Crenshaw, so Martha Crenshaw, Kimberly Crenshaw, sorry, was because when we think about the role of incarceration and how it impacts left behind family, it's not something to be thought of in isolation because there are different levels of societal factors that also work to marginalize these families. So for example, there is the aspect of access to justice. There is the aspect of stigma that they face from the society as a whole, where they can't really feel confident coming to seek for help. And then there is the aspect of poor access to mental health support and issues of financial constraints. So all of these factors does intersect to impact on parenting and all of that. So I'm going to be speaking of the findings in the next slide. Okay, so in terms of the systematic review, one of the key findings that we got from the impact of incarceration on these left behind families is the issue of stigma and the aggression that they face. So regardless of the country, whether that's in Nigeria or whether that's in any other part of the low and middle income countries, what we found is that this family face recurrent stigma, and that stigma in itself, not just an impact on the left behind family, but also on the primary caregiver that is providing that parenting support for the children. So when they're facing the stigma, it sort of have a vicarious effect, because one thing I know for certain is that you can never give what you don't have. So a depressed mother or a mother facing anxiety or trauma is less likely to give the child the best support as possible, because that has a ripple effect in how, for example, she would play with the child, interact with the child, and all of that sort of thing. And then there is also the aspect of neglect underpinned by poor support. So the neglect that they face is multifaceted. So they face neglect on the part of the government, they face neglect from the societal perspective, and they also face neglect from their familiar perspective. So for example, when the husband is incarcerated, other family members see the woman as the cause of the misfortune. So she faces that neglect, and then that means she doesn't get the support that she needs, whether that is in the form of emotional support, financial support, or any other form of support. And then one central recurring theme across the synthesized study was the behavioral challenges and crime. So when a child is obviously affected by incarceration, whether that's the incarceration of their father or mother or primary caregiver, they tend to then develop behavioral challenges if that is not being provided with appropriate support. And that, for some of the children, leads to engagement in things like antisocial behaviors and also then crime. So we begin to see a pattern of intergenerational offending, which again alludes to previous studies, especially within the context of the UK, that if a male child has a father in prison, they're twice as likely to end up in the same pathway and offend just like their father. So we're seeing that cycle of intergenerational offending. There is a lot of psychological issues, things like trauma, depression, anxiety, that comes as a result of having a family member in prison. And again, that's sort of tied to the cultural aspects in some of the studies that we found. So for example, in Nigeria, where the head of the family is the father, and also considering the fact that majority of those in prison are male, it does have a ripple effect, because if the head of the family, who is the breadwinner and primary care provider of things like financial support and everything, is in prison, it does distort the hierarchy of the family, where the mother is now forced to go and work, and then the children are then left behind, and then that leads to a lot of issues like trauma, anxiety as a result of that aspect as well. So in terms of intervention, there is very, very limited intervention that is targeted towards even the children themselves are affected. The only interventions that we found were psychoeducation, and this was for spouse, which husband is in prison, narrative group therapy for children. Again, this was just done in one country, which is quite shocking, because one of the things we found is that the children are mostly the one that suffer the most as a result of this. But a lot of the times, these families tend to resort to self-help in the form of faith-based intervention, whether that's in the form of getting informal support from the imams or pastors or whatever faith-based group that they are affiliated with. But we couldn't find any form of parenting intervention that was targeted to the primary caregiver that provide care for children and young person, which definitely then prompted us to do the empirical study. So with the empirical study, what we found was quite similar to what we found in the systematic review. So for example, we found externalized stigma and vicarious punishment, which was something that in a sense leads to that sense of psychological distress. So you'll hear the mother saying things like, she has been stigmatized against for the crime her husband committed. So even if she was not the one that committed the crime or was convicted, society just have a way of saying if her husband is in prison, she's as well a criminal like the husband. So that's like an externalized stigma for something that she hasn't really done, yet she's bearing the brunt of the punishment, and it's then seen as a vicarious punishment. So whilst the husband is serving time in jail or in prison, she, as the mother of the children that are left behind, is also serving her own punishment just because she's a wife of someone that is incarcerated. And then we found revolving cycle of crime. So again, some of the women talked about, for example, how their children, obviously because of what they were going through, poor parenting, and how their children ended up being caught up in the cycle of offending and then just in prison like their father. So again, reaffirming some of the points that have been found in Western studies, that if a child is have a family member incarcerated, they're twice as likely to offend in their lifetime. Psychological distress, a big one. There was a lot of issues of depression that the parents, the primary caregiver was facing. Depression, the shock of being the one to cater for the children, especially for the men whose wives were in prison. It was kind of like a shock to take on that responsibility to provide for young children as young as, for example, 4 years old. So they couldn't fathom what they were supposed to be doing, and that does impact on their psychological well-being as well. And then we found issues of poor support and extortion. So whilst this family are going through the shock of having a family member incarcerated, but they are also faced with extortion from other family members who would pretend to want to help them and then take advantage of them, and also extortion from the law enforcement agency. For example, when they need to visit their family members in prison, they'll get extorted. If you pay XYZ amount of money, then they're likely to fast track the visitation. So those were some of the key findings that we saw as a result of the 2 studies that we've conducted so far. And in terms of the next step, again, so yeah, some example of some of the quotes, because I was quite mindful of time. So if you look at these 2 quotes, you find that, so again, the first one was from a female carer of left behind children with the father incarcerated. So obviously the mother left, and so she's then left with the responsibility of caring for her brother's children. So she talked about in that extract how one of the son obviously was there when the father was arrested, and the father was actually again found guilty and currently serving imprisonment sentence for armed robbery. So the son was actually very much affected, and over time he ended up engaging in antisocial behavior, fighting in school. He was expelled from school and then eventually ended up committing crime. So at the moment, the son is also incarcerated. So intergenerational cycle at play. Then the second extract is from a mother whose husband is in prison. So she's a mother of 4. And she was just reflecting on her experience of having to take care of the children all by herself. No support from the government whatsoever. She's going through issues of anxiety and all of that sort of thing. She's left to parent these children with no support. And she was actually talking about what could help her in the current situation that she's in. So she was talking about the need for effective parenting intervention, because when the husband was incarcerated, she couldn't really know where to start from. He was the primary provider of all of the economic needs for the family. Now he's gone to prison for a very long time. She's left with the 4 children, and that sort of made her really, really concerned, because she didn't really know how to process what she's going through alongside the parenting of those children. So she was just reflecting on what sort of intervention would be helpful, intervention to tackle a recurrent trauma, the anxiety she faced, as well as the diverse emotions she was going through. So these are some examples of some of the extracts from the data set.
Torella, couple more. You have a minute or so?
Yeah, so just in time. Thank you.
Okay.
So in summary, what I would say based on those 2 studies is that there is a need for parental intervention for these affected families, especially those that are with the sole responsibility of providing that primary caregiving for their children, for their young children. Because without those interventions, what we are seeing is a recurrent pattern of intergenerational offending, and that is something that is recommended. So such a parenting intervention, obviously, there might be some adaptation if your interventions have worked elsewhere, and that intervention is encouraged to be culturally appropriate to support this affected family and tested using randomized control trial as the case may be. So I'd like to acknowledge the Manchester Global Foundation support in this, as well as Teesside University, Dong Ji Dong Foundation, and Terry White Legal Chambers. And here are some of the selected references that inform the presentation. Thank you very much. Thank you.
Well, thank you very much, Torella.
Thank you.
This is a wonderful presentation. Well done. And thank you for continuing this important work. Best wishes in this work with left behind families. This was some new information for me.
Thank you.
Dr. Nusrat Hussain, as you know, is a driving force behind these global conference on parenting interventions. And we've asked him to speak to future research collaboration as well as closing comments. Nusrat?
Thank you very much. You're so very kind, Andrew. It's you and Rabia who are the driving force and really making it happen. So thank you very much for another excellent year. I think this platform, there are not many such platforms I know of across the globe. So when we started, I think it was Usha who said, childbirth is a miracle, and all the talks have been brilliant. But what we see is we see some examples of scale up, but not many. The one Professor Mashriqi was talking about, I know Bala Mandir is doing excellent work across large population. Naseem and their group has brought in learning through play in routine care now. So that's brilliant, and that's one of the interventions. Obviously, one intervention does not fit all. And looking at the number of presentations and the work which is being done or have been done, we need to look at how we can bring it to maybe a central point. When we talk about maybe a network or a collaborative, what should the collaborative look like? Should we build on the advisory group and we have set up with regard to learning through play? What should be, the single point of contact where then people can be signposted and help to make that engagement, not only sharing the email address, but if there's, say, interest from Nepal to do a certain thing with colleagues in Peru, how we can be supporting that engagement and looking at. So we, along with the advisory group, maybe we can look at quite a number of people present here or who have presented in the past are part of an informal group which is called Global Mental Health and Culture Psychiatry Group. Some of the things which we do and we are very proud of is research capacity and capability building. I keep on coming to the example of Dr. Mashriqi because it's important that he's talking about hundreds of thousands of children and hundreds of thousands of families. And we need that kind of approach, even if we want to make a little difference. We know about the gap. We looked at, the prevalence figures which were presented about early child development challenges across the globe. Those figures were probably for US, but across the globe. One of the other things which we think more from the point of view of low and middle income countries is because that's where 80% of the population is, and they are 160% of the needs. And the investment is probably 5 or 7%. So we need to look at, I'm not talking about the high income countries bringing the investment there. I think the people there within those settings would bring in, there have been great, kind of movements as well, the work which, say, we've done in Pakistan on suicide prevention. It was more the community coming forward which has made it happen, that things are available in routine care. But a central focus would be required. The interest of high-income countries like UK would be learning from these low-resource settings. Many of us are working in the UK, and we know about the massive treatment gap within the UK. What can we bring in, particularly the excluded groups, like low-income population, the families which are ending up with their children in foster care. So a lot of things which we learn can be then implemented in high-income country settings as well. So again, coming back to Tarela, you've closed the work with systematic review and qualitative work, both hugely important. I think one of the things as a collaborative and a group we can do is offer supervision to people who are interested in doing, starting with the scoping review, whichever area they're interested in. As a group, we will be able to offer that. We, as a group, also support the training which is an online training by Cochrane in systematic reviews. So in high-income countries, it costs about £400, which we fund for high-income countries as well. But for the low and middle-income countries, it comes free. There are a number of questions which have come up in the presentations. You try and get one solution and one answer, and it raises 10 other questions to explore and look for. So that's the thing. Maybe this collaborative or the advisory group can be the central focus and look at it. If I just talk about one program, which is Learning Through Play, which is where I met Andrew and Shella is the one who introduced me. And one thing I clearly remember in year 2000, 2001, which has been one of the drivers of producing evidence. I went to see a colleague who was the head of UNICEF in Pakistan. And he said, yes, Nusrat, Learning Through Play looks excellent. But he said, at least once a month, somebody would come with another intervention, which he or she talks about, how it's so wonderful. What evidence do you have? So though it has taken us a long time, but I think we have achieved our purpose for Pakistan, that Learning Through Play is in routine care. So I would encourage other countries we would be able to support for. We have looked at EMDR. There was a talk about trauma. You've seen the presentation for schizophrenia. There are other interventions which are also with or without LTP are looking at parenting interventions. And this forum has been great. In the third conference, Mary Yap presented, and we have been, we want to share the news which Ume Lala presented, that in this year we have been able to get a grant from Grand Challenges Canada to test it in Pakistan. So there are a number of opportunities. I would be reaching out to most of you to look at how can we take this work forward. One of the large funding source which I've been talking to Andrew about is called the Wellcome Trust. And they are probably, if not the largest, one of the largest funders of health research. And I think looking at, again, Learning Through Play platform in 15 countries, give us a great advantage to look at that, yes, this intervention is working, similar interventions are working, but how is it working? What is the mechanism that it works? So Wellcome Trust is interested in that. I will also be reaching out, but feel free to drop an email to Rabia, Andrew, or any one of us. I think one of the presentations ended with older adults, something Bernard Shaw, about the play. I want to share with you one of the other things Shella has introduced me is Montessori in dementia, and we have done and published on it. Maybe we need to look at something around it. There's a lot of loneliness and exclusion of older adult population. So I think that is again something to think about. And these examples of what has been done in Bangladesh, bringing it to the UK, what has been done in the UK, taking it to Nigeria. I think this excellent 360 degrees learning is brilliant. And meeting like this give us an opportunity to look at what things have been done. One of the other things, if this is such a massive need, which we see, And we know that 50% of the disorders have their origins before the age of 14. That's massive, and this window of opportunity also. But there's not a lot of funding, there's not a lot of work. It surprises me. But one thing which we did not talk about, I want to say in my last minute, is the artificial intelligence and the digital bit. We'll make sure next year, we have some of those presentations. And please feel free to write to all of us. What would you want? It would again be in the last week of May next year. So I would like to thank all the audience who have been so brilliantly engaged, people who have presented over the 2 days. It's been excellent. Rabia, you are a gem of a person. Well done. And Andrew, thanks for the leadership. Yes. Thank you all. And bye-bye.
Can I make a comment, please?
In the chat.
Andrew, can I just a quick
You've
one?
got to go.
I'm hoping
Okay.
hoping we could talk about sustainability of these projects as well in the future.
Okay, next time.
Thank you.
Okay. Khuda Hafiz. Bye-bye.
Thank you all. Thank you, Nusrat. I'm always inspired by your vision for international cooperation for families. Again, thank you, Rabia and Naseem and your technical crew there. And a special thank you to the speakers. Blessings to you all. This is something to write down now. Next year, we're going to have the 5th annual Global Conference on Parenting Interventions. The dates that have been set now are Wednesday, May 27 and Thursday, May 28 of 2026. We decided to get a good start on this, so we have lots of time to think about it and plan for it. So blessings to you all, and thank you very much.
Okay, bye-bye.
Bye-bye.